If it's the first miscarriage, we don't do anything. But if in recurrent abortion, so a microarray, a low density microarray or a subtelomeric MLPA is good enough. It's better than a karyotype because a karyotype, like I said, needs living cells, so the diagnostic yield is just 50%. So a microarray is quite all right. Yeah. Thank you so much. Thank you.
As an obstetrician, for me, it was a brainstorming session. I have been practicing obstetrics, and definitely, like many of you must be doing now, we have been prescribing prenatal genetic testing in the form of a dual marker, an NT scan, a level 2. And I sometimes do it because it is a routine now. Sometimes I do it out of fear of medical legality. Sometimes because the patient asks for it. Sometimes I have to interpret reports which I am not really satisfied with. With all these confusions, I don't mind admitting that over the period of quite a few years, I was realizing that obstetrics now is incomplete without fetal medicine. And probably that ongoing feeling within me, I desperately wanted a fetal medicine person beside me for my every patient. And not because everybody is here, but honestly, I could achieve this when I had Dr. Savita Bansal madam sitting beside me in the OPD, and my every patient getting a counseling before going for a test. That do I need this test or I need something more? And after the test, is the interpretation by me enough? Even if I have fears, I have to think twice, thrice before I tell the patient, do a sonography again, do a test again. A patient is coming with something like low risk, intermediate risk, and now how do I counsel? Do the test again, do at a particular lab. These are all costly affairs. Like ma'am said, there are many limitations in India when you actually practice obstetrics. There are financial constraints, and above all, for me to understand is, my ability to practice genetics as an obstetrician, am I capable enough? I have no hesitation in saying it is such a vast subject that I cannot do it. I don't know how to thank Dr. Ratna madam, but I realized today that probably what I was thinking was not just a fear, it is actually a fact. Fetal medicine is a very important aspect of obstetrics now. At Eternal Mom, I'm really blessed to have Dr. Savita Bansal madam beside me and doing it for me, for all my patients. Thank you, Ratna ma'am, for a very enlightening session for all of us. I request Dr. Rajiv Bansal sir to felicitate Dr. Ratna madam, our guest speaker.
It's a pleasure.
I request Dr. S.T. Sharma sir to I request Dr. Rajprabha madam to felicitate our second chairperson, Dr. Shashi Gupta madam.
Sir.
Photographs to the star are very important.
Vishnu.
I invite Dr. Prem Mittal madam to felicitate Dr. Malika Swarup ma'am, Dr. Premlata Mittal ma'am. Dr. Premlata.
You also?
Ma'am, felicitations. Thank you all our chairpersons. I would now invite Dr. 𝐡𝐢𝐿𝐥𝐿𝐴, who's with us at Eternal Mob. She's an obstetrician and gynecologist, to take forward the program and start with the next session, which is a panel discussion. Dr. 𝐡𝐢𝐿𝐴.
As a panelist, Dr. Sunita Vishnoi ma'am, Senior Consultant at Cocoon Hospital. Dr. CME Bukhwarna ma'am, renowned gynecologist at her own setup, Aditya Hospital. Dr. Rekha, fetal medicine expert at Mahatma Gandhi Hospital at her own center. Dr. Neetu Rajvanshi ma'am, consultant at Metromas Hospital. Dr. Satyam Veda, consultant at Eternal Hospital Sangani. And Dr. Anupama Gangwal ma'am, consultant gynecologist. Cocoon Hospital. Dr. Seema Jain. Dr. Seema Jain, consultant at Monilek Hospital and Surya Hospital. So please. Dr. Imani Sharma, she is the clinical head at Cocoon Hospital.
So it is just a trial to involve all of us. So fetal, it's a time to integrate fetal medicine, genetics and obstetrics, because finally all of us together have to give a good outcome. So I've made few questions simple, but we see day to day. So we'll practically come out with practical solutions, and in the audience Dr. Ratna is sitting, and talking in front of her is very difficult for me. So the first question is for Simmi madam. So we had a patient, she was primary gravity.
I don't get an ultrasound done at 16 weeks. I normally get it done around 13 weeks or so.
Yes.
It would be an accidental ultrasound.
Yes, it's an accident.
Then it's very difficult to advise MTP to such patients, because I need to find out what is the reason of this omphalocele. If it is associated with other abnormalities, which may not appear at this time, so I'll just ask the ultrasonologist to look for other abnormalities, and around 17-18 weeks she might go for genetic testing also, because at least 30 to 50% of these are associated with chromosomal abnormalities. And that's it. I mean, I would say that first it has to be diagnosed. If it is with other abnormalities or chromosomal abnormalities, I would then advise termination. Or if it is not associated with other, if it is isolated, then I would advise and suggest that it has very good results of surgery, so it can be carried to term.
Thank you, ma'am. So this was one of our cases, and she came to the clinic with 17 weeks with omphalocele, and she was in shock. So counseling was done that it is associated with 30% are associated with chromosomal abnormality. So they somehow opted for, and there are some prognostic markers, like if liver and heart is also herniating, then the prognosis is really bad. So in our case it was there, liver was herniating, so the prognosis looked bad, but family wanted an answer why it happened. So we offered an amniocentesis, they were ready for it, and it showed a trisomy 18, good that a diagnosis was made. See, at that time we think कि diagnosis होगा तो prognosis पे क्या फर्क पड़ेगा, but patient को बहुत फर्क पड़ता है, उसको समझ में आता है कि it was a genetic cause which is non-recurrent. So patient का satisfaction level बहुत improve करता है. So instead of saying कि अब क्या फायदा, बच्चे को कोई फायदा नहीं होगा, we must try to find out the case. In the present era of people thinking scientifically, doing lot of Google, so at least they know that their omphalocele was non-recurrent and it was a trisomy 18. So then it was terminated, and as Dr. Ratna said, autopsy is important because this fetus has a cleft lip palate also, which was not detected on ultrasound. Whatever good ultrasound we do, how much training do we have, it's a known fact that if we do autopsy, we get additional findings at least in 20% cases, which can change the diagnosis and can reach to a better post-test counseling in the future pregnancy. So this was just an addition. At 13 weeks, omphalocele was detected, and they directly terminated. They did not go for any genetic testing. So it's fine. We have to counsel and tell them that it is for their satisfaction to understand and know the cause of abnormality. So for all abnormalities, there are two categories of abnormality. One are with bad prognosis associated with lot of chromosomal abnormality, and in those cases we must try to do a genetic test. May it be amniocentesis, may it be fetal tissue, which can be sent for microarray, and if patient cannot afford, at least QF-PCR can pick up aneuploidies. So instead of not doing it, let's start including QF-PCR also as a part of genetic testing in, at least in fetal tissues. So next question for Dr. Smita, she has not come. So can I give this test to question to Dr. Neetu Rajvanshi? चलो छोड़ते हैं. Dr. Smita का question छोड़ देती हूँ.
Madam, can we ask a question in the previous one? Had it been an exam follows right in the beginning rather than omphalocele, what would have you done? Again, we
Yes, sir.
exam follows. So
Yes.
should it not be kept full?
You are talking about gastroenterology?
No, exam follows total absence of anterior abdominal wall. Gastroenterology.
So, like in omphalocele and exam fellows, the prognosis is bad. Surgical results are also not very good, especially when the liver is herniating and on the heart is herniating. Whatever we do, if the baby is chromosomally normal, then also surgical results are not good. And we must not forget that this is only 16 weeks pregnancy. There is much to grow inside. Maybe the baby will have hydrops, maybe baby will not survive. All these things also we must understand. And doing a counseling with pediatric surgeon at 16 weeks doesn't correlate well, because 5 months beech mein aur hain. The pediatric surgeons, they generally see the live baby with that abnormality.
If it's a small omphalocele, it tends to close when the baby
Yes. Okay. So, so another patient, Dr. Neetu, for Dr. Neetu Rajvanshi. She is a 25-year female whose child is diagnosed with thalassemia major. She is worried. She has come to you. She is worried about future recurrence. What counseling will you do at first step?
Good afternoon, everybody. Ma'am, this is the present child or the previous child?
First child only.
First child, she is the primary.
The child is 9 years old and the diagnosis of thalassemia major has just happened. Pediatricians have explained, but she is worried about future recurrence. So that is why before pregnancy she has come to you.
Yeah, before antenatal.
For pre-pregnancy counseling.
Pre-pregnancy counseling.
She is not pregnant.
Yeah, because one of the child has been already diagnosed with thalassemia major, so we have to go for the pre-genetic counseling. Pre-genetic counseling means we have to go for the genetic mutation, particularly the DNA sequencing, particularly the mutation which has caused the responsible for this thalassemia major. And when at the second pregnancy she conceives, we have to go for a CVS at 12 to 13 weeks along with the sonography, and CVS to detect the particular gene mutation.
Thank you, Dr. Neetu. You have very rightly said, and because we as obstetricians we must all know something about thalassemia major. It's a blood-borne disease, not very uncommon. It is autosomal recessive, and prevention is better than cure, because whatever we do, there is a lot of problems and the child doesn't have a normal life, family has to spend a lot of money. So prevention is better than cure, and prevention is easy. We can do carrier testing, we can do coronary sampling, and it's a good habit that whenever a patient comes to you with a diagnosis, please you also see the papers yourself, because sometimes we see S beta, sometimes we see E beta, sometimes we see other type of hemoglobinopathies. So always develop a habit of seeing the reports. They can be HPLC or hemoglobin electrophoresis with a very high HbF, and the DNA sequencing, beta-thalassemia gene mutation sequencing. And if it is not done, please do it before sending the patient for coronary sampling. It's a good habit, because sometimes if we don't detect mutations, or sometimes if it is an abnormal diagnosis, then it is very difficult for us to explain. Then it is an autosomal recessive disorder, 25% recurrence risk, all of us know, and extended family screening also is important. Please develop a habit of drawing a pedigree, and if there are other family members in the family who are planning pregnancy or can plan pregnancy, some counseling of extended family history screening should be done at our end. That way we can diagnose more or more silent carriers of beta thalassemia. So this I have taken. And always suspect thalassemia, learn to suspect thalassemia trait by CBC only. So if we start looking carefully CBC, we can suspect thalassemia. MCV is less, Benzer index is less, and HbA2 we all know is more than 3.5. So this is just CVS. We all know if it is in safe hands, there is no need to worry of abortions, though we do counseling, but the risk of abortion in thalassemia patients is very, very low. I don't know what is the reason. Dr. Rekha is with me. We have never had a abortion in thalassemia major. CVS में कभी भी नहीं होता, because in double marker positive cases, some of the cases are those cases where placenta was poor. That is why markers were positive. That is why abortions occur. But in coronavirus sampling in thalassemia, we have been doing from last 25 years. नजर लग जाती है, but कोई abortion होता नहीं. ठीक है? So please don't worry about abortion. And it is in expert hands. It's just a 15-20 minutes procedure. It's an OPD procedure. It is done transabdominally. Transvaginally is not done nowadays because infection rate and abortion rate is very, very high. So just for filling the paper we take abortion risk, otherwise it's not there. This I am telling because I have seen few Google people coming for PGD and NIPT for thalassemia major, but literature says that PGD and NIPT still their sensitivity is not known, so CVS is still the standard of prenatal diagnosis of thalassemia major. Dr. Deepa?
Madam, just suppose you have diagnosed in the second pregnancy that it is thalassemia again, then how do you cancel? Should the child be kept?
Sir,
it is a curable disease otherwise.
Sir, in prenatal, it is a rule that before doing the procedure, we do a pre-test counseling.
Agreed.
We always ask them that if a disease is diagnosed, the options are termination of pregnancy. So if they are ready for termination of pregnancy, then only we'll do a CVS. Otherwise, why will we do?
I mean to say that whether it is necessary to terminate the pregnancy thalassemia major.
No, it is not necessary. It is the family's wish.
You have to explain the family.
Yes, but if somebody has come for a invasive procedure, taking the risk, then they have to understand that we are not going to do any in utero treatment, no gene therapy, no magics. The bone marrow transplant have their own problems. All these things we'll tell them before, and then if they are ready, that we are ready for prevention, not for cure, then only we'll do a coronavirus sampling and amniocentesis if it is late. And you have heard some news that this baby born with the cord blood matching and all. This is all unethical. We cannot do all these things for a ongoing pregnancy. Yes. So Dr. Deepa, it is a 28-year female. She had a previous child with Down syndrome. Worried for recurrences in next pregnancy. What counseling will you do? What papers will you like to see? Will you like to see the proband or not?
Yes, since this couple is already having a previous child with Down syndrome, so no doubt a good counseling works out here. And if the couple wish to go for karyotyping for themselves, we can go for that, because the chances of recurrence, though it's 1 to 3%, and a translocation gene can be found in one of the partner, and there are chances of recurrence, then we have to counsel for them that how much recurrence rate is there and how is it diagnosed once they carry the pregnancy. So in any case, even if they go for their own test, once they conceive, they have to go for testing during first trimester itself. So no doubt the counseling plays a very important role, and we have to look for all the whether that child underwent autopsy and what kind of was it a trisomy itself or a mosaicism or a translocation. So that those kind of like history and autopsy reports are important to counsel them for next pregnancy, and then we have to ask them to go for it, and the prenatal testing can be done in these cases.
Thank you very much. Down syndrome, there is lot of learning and conditioning and sensitization of Down syndrome. But as a geneticist or as a obstetric people, we must realize that there is mental retardation is much more than beyond Down syndrome. Because many times we see people see mental retardation with some dysmorphism, they label it as Down syndrome. So please, we are going to do an prenatal. As Dr. Ratna rightly said, first confirm the diagnosis in pro-band. Down syndrome is easy. By looks we generally identify, but develop a habit of seeing this report, karyotype. If it is karyotype, chromosome number abnormality, if we do parents karyotype, it may not help. But if it is a translocation, there is an extra 21 on 13 or 14, then yes, parents karyotype is important because many of them are familial, and familial Down syndromes, they have a slightly larger recurrence risk. It is about 5 to 15%. So recurrence, and only one familial translocation, 21 has a 100% recurrence risk. I saw 2 patients, what to counseling, what to tell them, I could not understand, because they were very, they were not educated people. If I tell them that you have 21 translocation, the lady was having 21 translocation, and you have 100%, she had 2 Down syndrome babies already, and she came to me for counseling for 3rd one, and they are going to change the wife. It was that family, but for educated one, you can tell them that she needs
Suicide donation can be the answer for this. Suicide donation.
Yes, suicide
Okay. Yes, for educated one, egg donation is the answer. This is the only chromosomal genetic common abnormality that there is 100% recurrence risk. Otherwise, Down syndrome, if it is not a translocation carrier, then the recurrence risk is 1% more than age. So when she becomes pregnant, if the same lady becomes pregnant.
So now this lady who has Downs, two previous Downs.
No, not this one. The other one which we were discussing, one child with Down syndrome, trisomy 21 on karyotype.
So one child with Down syndrome, the lady comes to me pregnant. I advise her. It's okay. Is it clear? It's okay. I think everybody can hear.
No, we cannot hear.
Take the other one.
Thank you.
Thank you. So what I suggest is that she goes in for her the first trimester scan primarily. A detailed an FMC, a fetal medicine consultant, or any other who's expert at first trimester scan goes through that, and then along with for such a patient, I would not go in for the screening test. Personally, I would ask her to go for a definitive test, because the other tests are only screenings, and that 1% of doubt is far too much. And at this stage of CVS would be very accurate, and just now our FMC experts were saying that it is without risk, and if you compare the background risk of definitive test of CVS, it is just about 0.21% as according to Cochrane databases. That's all, I guess.
Thank you, ma'am. So all answers you have already given. Double marker doesn't help in previous Downs because the screening is, she's already normal, kidney normal. So we are following this pregnancy. Now the pregnancy reached at 26 weeks. We found oligohydramnios, and growth was okay. But uterine artery Dopplers were going down. So we were cautious that she's a high-risk case of IGR and preeclampsia. And when the pregnancy was followed, it was a 36 weeks she had preeclampsia and pregnancy was terminated. She got a normal child. But we were vigilant enough and we understood that maternal serum alpha fetoprotein, if it is high, and because 3D scans nowadays are very good and people have become experts, they are almost equivalent to MRI. Problem with fetal MRI, though we read in books fetal MRI, but who will report your fetal MRI? Tell me. Nobody is going to do. Second, expertise. Third, fetus will move, so the MRI sequencing will not be that good. And the difference in diagnosis and the help in fetal MRI applies to those countries where open neural tube defect they do not terminate. There are some countries, the neural tube defect, they operate in utero. So MRI is for them. Do an MRI, understand which type of neural tube defect it is, operate and then follow. And also if we miss the neural tube defects in 3D, they are generally closed or occulta, which are not lethal. So instead of going for fetal MRI, get a good 3D and please understand that there are other causes also and follow the pregnancy instead of terminating and making them afraid of neural tube defects. So this was another case where IUD happened because she was 40 years. So we did an amnio also because of 40 years. She came for high alpha fetoprotein because I was doing an invasive, so I also did amniotic fluid alpha fetoprotein level. Luckily it was normal, but if it was high, then there is no known sensitivity or specificity, because sometimes alpha fetoprotein can be high because of hemorrhage, fetal hemorrhage, which is difficult to prove. So it is written that if you don't see neural tube defect in ultrasound, even with a high alpha fetoprotein in amniotic fluid, should we really terminate the pregnancy? So why should we do it? Okay? डॉक्टर सत्यम बता, मैंने तुम्हारे सवाल का जवाब तो मैंने दे दिया।
वो मैंने कहा हमने सारा
so sorry sorry आप बताओ, is good ultrasound sensitive for open NTD? Is there any role of MRI or 3D? How will you follow if 3D is normal? अब जो मैंने नहीं बोला वो बोल दो तुम।
The panel has already discussed and madam has rightly told all.
So this is very, very important.
And as far as MRI is concerned, as madam told us, like MRI 3D is now becoming equivalent to MRI in our gynec mullerian anomalies also. So it is more important to detect the soft tissue anomalies. So in cases where outside our country where they are doing in utero surgeries, their MRI plays a major role. And last one. And I would say,
has amniocentesis any role?
if my fetal medicine specialist friend says that there is no structural anomaly, then I would not go for an amniocentesis, but I would definitely follow the patient and counsel her that her pregnancy is a high risk pregnancy that needs to be followed at the bedside.
Thank you. Dr. Imani. She was a primary gravida, 24 years, 17 weeks pregnant. Quadruple test was positive for trisomy 13. These are her levels. Develop a habit of looking into M1.
Yes.
M1 is not screen positive for trisomy 13. Anti-scan was not done, only viability scan was done at 8 weeks. What hint you get? Would you like to add something?
Trisomy 13 has a poor prognosis, and looking at the low levels of MOM less than 0.3 all, we have to look for viability because it may be an IUD also.
That's the point. We develop the habit of looking at MOMs, and if all the MOMs are very, very low, please think either gestation age is wrongly calculated or it's an IUD. Confirm viability before proceeding for NIPT, amnio.
And then in detailed sonography, we will look for the other features of trisomy 13. Trisomy 13 have many features like microcephaly, holoprosencephaly, and then cleft lid, cleft palate, many heart abnormalities, omphalocele, clenched foot, then IUDR and sudden IUD in midterm, and even if fetus born, then also like they have very poor prognosis. The fetus dies within hours or in a day, most of them. For diagnosis, amniocentesis, we will not go for NIPT because it is again a screening test, and directly we will go for amniocentesis and confirm the diagnosis.
So this was one case which was
I don't
referred
think
to us.
this will reach to term. This pregnancy may not reach to term. Multiple anomalies, IUD.
So the idea of putting this here is always look at MOMs. Don't just look at trisomy 13 high risk positive. Learn the habit of looking at MOMs. And most of the fetal medicine people don't need amniocentesis for diagnosing trisomy 13. 13, 18 they usually pick up. Only 21 is the problem which we cannot diagnose by 100%, and that is why we do amniocentesis. So this was an IUD, this was one of our case, and when we terminated the pregnancy it was a triploidy. They wanted a chromosomal microarray, we did a microarray and it was a triploidy. So Madam, Dr. Sunita. It was a case where her CRL was 66, NT was 3, nasal bone was seen. She is a primi gravida. Cord is no, so she's second gravida, 36 years age, previous child normal, and NT scan otherwise was normal. All other things were normal. Only NT was 3.
CRL with this CRL, NT is 3 millimeter is more, so we can suspect neural tube defect, and we will investigate her accordingly, and we'll follow the patient.
So what is important to understand that there are softwares we can do on perinatology. We
will do a double marker, and the nasal will go for nuchal thickness and other.
We have NT has a cutoff according to CRL. So every CRL has a centiles. So this is the chart which is showing that at 66 we are beyond 95th centile.
More than 2.5 is abnormal at any centile.
Yeah, 45 to 80.
At any
85,
centile.
So it is more than 95th centile. So if it is more than 95th centile, there is high risk for chromosomal abnormality, and she needs a.
But we should know the exact gestation. If it is done after 14 weeks, then
they normally don't do NT. Normally they should not report it.
They should not report, but sometimes the patient comes late and we do the sonologist does it and we take it, interpret wrongly. NT is less. That after 14 weeks the fluid starts decreasing. Nuchal thickness fluid that start decreasing and we get a wrong value. So it should be done 11 to 13 weeks.
NT, there are certain criteria which should be done between
11 to 13 weeks.
45 to 88.
And the centiles are according to. Sorry, I'm saying the centiles are according to CRL. So we must develop the habit of seeing the centiles in certain online softwares also. We can quickly do it. Perinatology has a software, perinatology.com, where we can put CRL and immediately you will get the centiles of NT scan. So if it is more than 95th centile, then only there is high risk. And if it is between 95th to 99th centile, see 93% has normal outcome. So instead of directly going for termination, if we understand this much, we can counsel them for coronary sampling. But if it is more than 6.5, see the normal outcome is only 15%. So accordingly the families we can counsel and they can decide. Accordingly they can decide. So this is, I have repeated, Dr. Rekha. 33 years gravida 2, came for antenatal checkup. Previous 6 years child is severely mentally retarded. She is 14 weeks pregnant. What investigation of proband will you do? CMA versus clinical exam. Any role of parents karyotype, will you go for CVS amniocentesis directly? If you want, you can come here and speak.
No, I understand. So in such cases, first we want to examine the child who is actually mentally retarded. So as the Ratna ma'am have told that so many investigation and tests are available, so we need to choose that which test we should order for the child. So for that we should characterize the phenotype of the child, whether it is going into chromosomal disorder or it is going into single gene disorder or it is Fragile X syndrome. So we need to check the child for that. And if the child on looking it is mentally retarded along with some facial dysmorphism is there or some chromosome, some other organ abnormalities there, like child is having single kidney, some abnormality, mild abnormality in heart. So if child is having multiple congenital anomaly, facial dysmorphism and mental retardation, then we fit that it is fitting into chromosomal disorder. Then we ask for chromosomal microarray rather than karyotype of the child, because microarray has high resolution and microarray also 750K high resolution microarray we advise. And if microarray is normal, then we should look other etiology also, like nowadays, because NGS and clinical exams are in hand, so sometime mental retardation is due to single gene disorder also. So we can offer them whole exome testing also in such cases which are undiagnosed by chromosomal microarray. And we should not forget Fragile X syndrome testing also in mentally retarded child.
Thank you very much. And I will skip this.
Can I just ask one
Dr. Seema, your
Sorry.
question is
Can I just ask one question
Yes,
first?
yes.
If we are ordering a microarray, do they look at the chromosome numbers anyways, the karyotype? Or they do only microarray?
In microarray, there are sequences related
No,
to
that
all
I
the-
understand. But suppose we are ordering microarray, but would they pick up like the number abnormalities, trisomy 21 and all as well?
Yes.
Everything. So it will be picked up.
Unbalanced, everything will be picked up.
Translocation-
Triploides will not
Translocation
be
will
picked
not-
up. Triploides will not be picked up, and any balance
Translocation will not
be picked up. Unbalanced anything, aneuploides will be picked up. Trisomy 18, 13, everything will be picked up.
So now, for the previous question, don't you think it's the prerogative of the pediatric specialist who was treating the previous
the child should have a diagnosis
he
by then,
should
but
have
sometimes-
a diagnosis,
sometimes
a
it is-
genetic. Sometimes yes, but I think that could be the way we could lead
Yes,
the
you can
patients,
send
that you
to-
first consult your pediatrician.
Actually, better
and-
is to go for a medical geneticist or
whatever.
specialist.
Yes,
But
he should
it's
be mentioning
consulted.
the exact, and then perhaps we can go
Yes,
forward.
yes, you should refer
Instead
them.
of us guessing as to whether the child has chromosomal or
yes,
whatever.
14 weeks, we
If we
still have
have
time
that,
for
then
a
it's a better way to go forward. I personally think
Yes,
that.
pediatrician or any medical geneticist
Or
who refer the
whoever he clinches, decides, and then you can perhaps
That
tell
is
the
how
mother
normally it should be.
as to which way it will go.
Yes,
we have a similar case.
Dr. Seema, question for you. 13 weeks cystic hygroma diagnosed on ultrasound. They have come to you. What counseling will you do? What will you want to do? What test? Whether termination, whether CVS? You want to counsel directly? You want to send to us?
I'll send to you, but I'll do the initial counseling.
We will send it to you.
Yeah, so now as far as the prognosis is concerned, we all know that in cystic hygroma the prognosis is quite guarded because quite a significant percentage of these patients, they have chromosomal abnormalities, Turner's being the most common one. I would offer invasive testing to rule out aneuploidies. Now, direct termination, obviously it depends on how big the cystic hygroma is, and the size of the hygroma, whether it is separated or whether it is not, and whether it is associated with other obvious anomalies. If there are obvious anomalies, then even though we offer the patient invasive testing, but sometimes they do not take it. If you tell them the prognosis is like 90% the outcome is going to be bad, only in 10% the outcome may be okay. So sometimes they may not agree for invasive testing. We'll definitely refer the patient to a fetal medicine person, but I feel that if the patient doesn't want to go for invasive testing and wants termination, it can be offered. Yeah.
That's the point. You can counsel yourself. Because in cystic hygroma the prognosis is so bad that invasive testing I think is not going to help, because we are not going to continue the pregnancy. And if the family can afford, then it is a better idea to do a genetic testing of the fetal tissue, not the placenta. So when you terminate, please send the fetal tissues for chromosomal microarray or QFCCR according to the pocket of the patient. So we had a case with Dr. Deepa. So she terminated, sent the patient to me. It was a Turner. Deepa, it was a Turner. Okay.
But I have seen one patient where the hygroma actually resolved.
Yes.
And then the baby was okay.
Yes, but another
That's
patient. See, it's a literature is according to the patients. So they say that in only 10% the outcome is normal. So if the family wants to take the chance, then you do invasive, then follow.
But Turners can be born and they can be like
Yes.
Yeah.
Okay. So thank you all panelists for such a nice discussion, for involving me.